We'll now turn our attention for the last portion of this to the embryology of the pharyngeal apparatus and related face and palate. So looking at this diagram, we're looking at an early embryo, and we want to focus our attention on the neck region here. And what we see in the neck region is a series of bulges or arches that are called pharyngeal arches. And in between those arches, we have grooves. Those are called pharyngeal grooves. Now, in order to really understand what's happening here, what we want to be able to do is look at not only the outside of the embryo in the neck region, but look at the inside at the same time. So to accomplish that, we'll make a section along that line like that, make that section, remove that, and look into the embryo from that direction. And this is what we would see. Okay, so we were out here before looking at the outside, and we saw those bulges and grooves. But now what we're able to see is the outside and the inside at the same time. So this inside, this is the gut tube. This is the upper end of the gut tube called the pharynx. If you remember, we said that the part of the gut tube that is rostral to the respiratory diverticulum is called the pharynx. When we talked about the gut tube, we talked about the foregut, midgut, and hindgut, which is the part caudal to the respiratory diverticulum. We said we would leave the pharynx for when we did the neck. So here we are now. So this is the pharynx. So if we go up in this direction, it leads us to the mouth. If we go down in that direction, it leads us to the esophagus. Now, in this embryo, if this is the outside, you'd expect that it's covered by ectoderm, and it is. If this is the inside, the lining of the gut tube, you'd expect that it's covered by endoderm, and it is. And then between the ectoderm on the outside and the endoderm on the inside, you'd expect this region to be filled with mesoderm, and it is. But not only mesoderm, lots of neural crest migrates into this region. So in between ectoderm and endoderm, we have a lot of mesoderm and a lot of neural crest. So each arch is covered by ectoderm on the outside, endoderm on the inside, and is filled with mesoderm and neural crest. We've already said that the ectoderm on the outside has these series of invaginations, which we called pharyngeal grooves. The endoderm on the inside has a corresponding series of evaginations of endoderm called pharyngeal pouches. So the pouches are endodermally lined, they're on the inside. The grooves are ectodermally lined, they're on the outside. Okay, and the arches are in between. You see that there are 5 arches, but they are numbered 1, 2, 3, 4, and 6. And the reason for that is that lower species have 6 arches. We only have 5, but we know that the one that we're missing is the 5th. So we number them accordingly. We number them 1, 2, 3, 4, and 6 so that we can make the corresponding understanding between us and other species. And then the grooves and the pouches are numbered according to the arch in front of it. Okay, so let's try to understand what's happening here. And a good starting point in understanding this is to just take a moment to understand what happens in fish, because after all, this is all really just a developmental throwback to fish. So what happens in this region in fish? In fish, each of these grooves, each of the grooves gets very deep, and each of the pouches gets very deep. The ectoderm of the groove and the endoderm of the pouch fuse at each level into a double-layered membrane, ectoderm and endoderm. And then the membrane ruptures. And if the membrane ruptures, that means we now have an opening called a slit, or in a fish you would call it a gill slit, which is an opening between the pharynx and the outside world. And so we'll have a series of gill slits. What happens in fish is as the fish is swimming in that direction, the mouth is open, so water is flowing into the pharynx and then flows from the mouth through the pharynx and then back out into the ocean again through the slits, through the gill slits. And as the water is passing through these slits, it's passing right up along the surface of these gill arches, as they're called, And in these arches, right close to the surface of each arch, there are lots of blood vessels very close to the surface, so the water is passing right over these very vascularized arches, and that allows the opportunity for oxygen to diffuse from the water into the bloodstream of the fish. And that's how fish get their oxygen, by having water passing through those gill slits. Okay? So, what does that have to do with us? Well, what happens in humans is almost the same thing with regard to the first groove and the first pouch. It's almost the same thing. What happens in us is that the first groove gets very deep, the first pouch gets very deep, the ectoderm of the groove and the endoderm of the pouch fuse and become a double-layered membrane, ectoderm on the outside and endoderm on the inside. So far, that's exactly the same like fish. But the difference is, in us, the membrane doesn't rupture. We keep the membrane. And we call that membrane the eardrum, or the tympanic membrane. So that's where the tympanic membrane or eardrum comes from. It's a fusion of that ectoderm and that endoderm. Okay? It's a double-layered membrane. Now, if that indeed is true, if that's going to be the eardrum, or the tympanic membrane, that pretty much automatically tells you that that groove, which is leading us into where that membrane is, that groove must be the external ear canal. And it is. So we still have our first pharyngeal groove. We call it our ear canal. Right? We see that that first groove is sitting right between the first and second arches. So that means if you stick your finger in your ear canal, that means your finger is sitting right between your first and second arch. Well, of course, what's surrounding your finger when it's in there is the pinna of the external ear. And so that would suggest to us that the pinna must be coming from components of the first and second arch. And that's going to be true. Now, remember, we said that the arches contain mesoderm and neural crest. And what we're going to see is that the neural crest that's in those arches is going to give rise to cartilages and bones, primarily, some ligaments, but mostly cartilages and bones. And so the pinna, which is made of cartilage, is coming from the neural crest of the first and second arch, surrounding the ear canal, which is from the first groove. So that kind of makes sense. Now, if that's going to be the eardrum, if we go to the other side of the eardrum, so that we're now in the first pouch, we know that when we're on the other side of the eardrum, we're in the middle ear cavity. So that suggests that the first pouch must become the middle ear cavity. And that's true. That's exactly right. And you see that the first pouch is directly continuous with the pharynx. Well, that would suggest that the middle ear cavity should be continuous with the pharynx. And of course it is. That continuity we call the eustachian tube, or the pharyngotympanic tube. Eustachian tube, connecting the middle ear cavity to the pharynx. So that's what the first pouch becomes, the middle ear cavity and the eustachian tube. Now, you might recall that in that middle ear cavity, we're going to end up with some little bones, the ossicles, malleus, incus, stapes. Well, we just said that forming the boundaries of that cavity, we have the first and second arch, and we said that there's neural crest in both the first and second arch, and we said neural crest will give us bones. Well, we want bones in here, so what's going to happen is neural crest from the first arch will migrate into the cavity and will give us the malleus and the incus, and neural crest from the second arch will migrate into the cavity and give us the stapes. So the three ossicles, malleus, incus, and stapes, come from neural crest of the first and second arch. Malleus and incus from the first arch, stapes from the second arch. You may recall that in the middle ear cavity, we also have some skeletal muscles, two of them, called the tensor tympani and the stapedius. What their functions are, you'll talk about in neuroscience, but for right now, you have these two muscles in the middle ear cavity, skeletal muscles. We said that there's mesoderm in these arches in addition to neural crest. Well, the mesoderm is going to give rise to, among other things, skeletal muscles. So we need some skeletal muscles in here. We have mesoderm here and here. And so sure enough, mesoderm from the first arch will end up giving us the tensor tympani. Mesoderm from the second arch will end up giving us the stapedius. Okay? So now we have the the origin of those contents of the middle ear. Now, this is where everything really does become useful to know. We just said that there's mesoderm in each of these arches, all of them, and we said that the mesoderm is going to give us, among other things, muscles, skeletal muscles. We already know that wherever you're going to have muscles developing, you have to have nerves going to those muscles to innervate them. We talked about that when we talked about the limb buds. So that means we're going to have nerves going into each of these arches to innervate the muscles that are developing in those arches. It turns out there is one specific nerve or a cranial nerve or branch of a cranial nerve that is assigned to each arch. And we'll talk about all of them eventually, but for right now, let's just talk about the first and second arch. The nerve that grows into the first arch is going to be the mandibular division of the trigeminal nerve. And the nerve that grows into the second arch is going to be the facial nerve. So that means that any muscle that forms from the mesoderm of the first arch is going to be innervated by the mandibular division of the fifth nerve. And it means that any muscle that develops from the mesoderm of the second arch is going to be innervated by the facial nerve. Well, now that's useful, because now that means that if you know what muscles are innervated by the mandibular division of the fifth nerve, which is something you have to know anyway as you study neuroscience, you now automatically know that those same muscles are going to be innervated by the mandibular, by those same muscles rather are going to be arising from mesoderm of the first arch. If you know what muscles are innervated by the facial nerve, you know automatically that those muscles are derived from the mesoderm of the second arch. So, you really can do this either way. Either if you know what arch it comes from, you'll automatically know what nerve innervates it, or if you know what nerve innervates it, you automatically know what arch it came from. Choose one way or the other, because they both lead you to the same place. Okay? So we're going to have the mandibular division of 5 going into this arch, and the facial nerve going into that arch. All right, so now let's take a look at this as it develops a little bit further along. Okay, so further along in development, we see that that first groove has indeed gotten deeper, and we see it's now labeled as the external auditory hiatus or the ear canal. We see that the first pouch has gotten deeper. We see it's labeled as the middle ear cavity and the eustachian tube connecting it to the pharynx. We see that double layer of ectoderm and endoderm. We're labeling that the tympanic membrane. That's exactly what we said we were going to see. But notice something. On our previous slide, we saw a first groove and a second groove and a third groove and a fourth groove. And now on this slide, we're only seeing a first groove. What happened to the other grooves? What happened to the other grooves? So what happened to them is this. This second arch gets very big, really grows a lot, and overgrows, grows back and covers over all of the other arches, and covers over all of these grooves, and fills in those grooves. So the overgrowth of the second arch comes back, fills that in, fuses down, fills all of that in. So it all smooths over because of the overgrowth of the second arch. Okay, so that second arch came in, covered all of that over, filled in those grooves. But realize something, we've said this over and over again. When things are supposed to fuse together, sometimes they don't do so perfectly. So if, let's say, the second groove didn't get completely filled in and doesn't completely fuse down, you can be left with a little cyst right there where the second groove used to be. Didn't get completely filled in. And you would call that a lateral cervical cyst or a pharyngeal cyst, a lateral cervical cyst. Well, if you can have one where the second groove used to be, certainly you can have one where the third groove used to be or where the fourth groove used to be, right? Or any combination. So we have this possibility of there being what are called lateral cervical cysts, which are found on the anterolateral surface of the neck, right along the anterior border of the sternocleidomastoid muscle. And they're found at just below the ear, or a little bit lower, depending upon whether it's second, third, or fourth groove. Okay? The epithelium that lines that cyst is ectodermal epithelium because, after all, the groove is lined by ectoderm. Okay? So that's an abnormality resulting from a failure for the groove to completely fuse down and disappear. Okay? Normally that doesn't happen, so let's get rid of those cysts. Okay? So the only groove that normally does remain into the adult is the first groove, which is the external ear canal. Let's now talk about the pouches. We've already said that the first pouch becomes the middle ear cavity and the eustachian tube. The second pouch stays pretty much just the way we see it here, a little bit lower on the lateral wall of the pharynx, a little below the eustachian tube, has a little evagination like that, and we call that the tonsil of fossa. That's the tonsil of fossa, the second pouch. The mesoderm and perhaps some neural crest cells that underlie that here is what becomes the tonsils. Okay, so this is the tonsil of fossa with the tonsils forming right under that epithelium. Okay, so that's the second pouch. With regard to the third and fourth pouches, the cells that underlie those pouches, they become important things, but they don't stay where they are, they migrate. So the cells underlying the third pouch migrate downward like that, shown in that arrow there. They migrate down, some of them come down this far and then head medially. They're going to become the inferior parathyroid glands, and others migrate and keep going even further inferiorly all the way into the thorax to become the thymus. So these cells, primarily neural crest, probably some mesoderm as well, underlying the third pouch, become the inferior parathyroid and the thymus. Okay, but they have to migrate to get to their respective positions. Since they are migrating, not a big surprise, sometimes they can get lost and not end up where they're supposed to. So it wouldn't be a big surprise if some people, there was some parathyroid tissue down here in the chest where the thymus is, because some of these cells that should have stopped migrating to go here kept on going and ended up down here. So it's not that uncommon to find some ectopic parathyroid tissue in the chest, okay, because of errors in migration. Okay, so that gives us inferior parathyroid and thymus. From the cells underlying the fourth pouch, again, those cells migrate, not nearly as far. Some of them just migrate a little medially. They become the superior parathyroid, and others migrate and become incorporated into the thyroid gland, and they become the calcitonin secreting, or the chief cells, or the C cells of the thyroid. So not the thyroxine secreting cells of the thyroid, but rather the calcitonin secreting cells, or the C cells of the thyroid. So they come from the cells underlying the fourth patch. Because the superior parathyroid gland doesn't have to migrate nearly as far as the inferior parathyroid, it's not a big surprise to find out that the incidence of ectopic inferior parathyroid is more common than ectopic superior parathyroid. So if a surgeon is doing a parathyroidectomy for a patient who has parathyroid tumors or calcium metabolism issues and has to remove all of the parathyroid tissue and is looking for the parathyroid glands, it would be more common to find that an inferior parathyroid is not where it belongs than to find that a superior parathyroid is not where it belongs, because these had to migrate further, so there's more chance of them getting lost. Okay, so that takes care of that. But now we have to talk about, where did the thyroid gland itself come from? Where did the thyroid gland come from? And that doesn't come from any pouch. That doesn't come from the lateral wall of the pharynx. It actually comes from the ventral midline of the pharynx. There's going to be a ventral midline evagination from the floor of the pharynx. This is a familiar theme. We've talked about ventral midline evaginations from the endoderm of the gut tube several times. That was what the respiratory diverticulum was. That's what the hepatic diverticulum was. That's what the ventral pancreatic diverticulum was. They were all ventral midline diverticula. So here's one more, but this one's higher up to the pharynx. And it's going to be a ventral midline evagination, grows out ventrally from the floor of the pharynx, descends in front of the pharynx, and then the distal end expands, and the distal expansion becomes the thyroid gland. Oh, that's very similar to what we saw with the hepatic diverticulum, right? You had a diverticulum, the distal end expanded to become the liver, right? It's what we saw with the respiratory diverticulum, the distal end expanded to become the lungs. Same idea. So now the distal end expands to become the thyroid gland. Now, if that's where the story ended, we would have a thyroid gland with a duct, and that duct would open into the floor of the pharynx. And that would make the thyroid gland an exocrine gland. But that's not normally where the story ends. Normally, after the thyroglossal duct descends, expands to become the thyroid gland, then the duct fuses and disappears, leaving us with a gland without a duct. And so it's an endocrine gland. But, as you might anticipate, if what normally happens is that it fuses, sometimes perhaps it doesn't fuse completely. So you could have something like this where the thyroglossal duct incompletely fuses, leaving a little region here where it didn't fuse, creating a little cyst along the path of the thyroglossal duct. And that would be called a thyroglossal cyst, or sometimes you'll hear it called a median cervical cyst. In contrast to a lateral cervical cyst, which was a remnant of a pharyngeal cleft or groove, a median cervical cyst is a thyroglossal cyst derived from the thyroglossal duct. So this is lined by endoderm, because the thyroglossal duct is endoderm. Okay? The point of evagination from the floor of the pharynx, usually the only remnant that we see of that is a little pit in the midline of the tongue right there. It's called the foramen cecum. That's where the thyroglossal duct evaginated from, but now it's just a little blind-ending pit. We call it foramen cecum. But that means you wouldn't be surprised that sometimes you find some thyroid tissue right on the tongue, right around where the foramen cecum is. It would be called a lingual thyroid. It's some cells that didn't migrate and didn't descend. So you could have a lingual thyroid gland tissue that should have descended with the thyroglossal duct that didn't descend. Okay? Okay, so that takes care of the thyroid gland. So now the only thing left for us to look at is the arches. We've done the grooves, we've done the pouches, we've done the thyroglossal duct, and now we just have the arches. And we've already talked about a couple of the arches, and now we'll finish the story. So we said each arch will have mesoderm in it, and the mesoderm will give us skeletal muscles. We said each arch has neural crest in it, and we said the neural crest will give us skeletal structures, bones, and cartilages primarily. And we said that each arch will have a specific nerve grow into it and innervate the stuff that's in that arch. And so now we can do the details. Also listed here is that each arch will, from the mesoderm of each arch, there'll also be an artery, and that artery will be called an aortic arch. We're not going to discuss those. So the nerve that grows into the first arch we said was the mandibular division of the fifth nerve. The mesoderm of that first arch gives us these 8 muscles. We've already mentioned the tensor tympani, but now here are the rest of them. 4 muscles of mastication plus these 4. So these 8 muscles must be innervated by that nerve, and they are. The neural crest of that arch gives us a whole lot of the face, the maxilla, the mandible, along with the teeth associated with the maxilla and the mandible. Okay? We've already said that the neural crest gives us 2 of the ossicles, the malleus and the incus. Okay, all from the neural crest of the first arch. The second arch, we said the facial nerve grows into it. The mesoderm of the second arch gives us all the muscles of facial expression plus these 3. We've already mentioned the stapedius. Now we add those 2 plus all the muscles of facial expression. So all of those muscles are innervated by the facial nerve. More about that, very important when you do neuroscience. But all of that's derived from mesoderm of the second arch, and we know that because they're all innervated by the 7th nerve. The neural crest of the second arch, we already said, gives us the stapes, and now we can add to that, gives us the styloid process and part of the hyoid bone. And now let's finish the story with the other arches. The third arch has the ninth nerve growing into it, the glossopharyngeal nerve. The mesoderm of the third arch only gives us one muscle, stylopharyngeus, which means there should only be one muscle innervated by the ninth nerve. And sure enough, that's true. Stylopharyngeus is innervated by the ninth nerve, glossopharyngeal nerve. And the neural crest of that arch gives us the rest of the hyoid bone. And then the fourth and sixth arches each have a branch of the 10th nerve growing into it. Into the fourth arch, we have the superior laryngeal branch of the 10th nerve. Into the sixth arch, we have the recurrent laryngeal branch of the 10th nerve. The mesoderm of the fourth arch gives us one muscle of the larynx, the cricothyroid, as well as muscles of the soft palate and pharynx. So all of those muscles should be innervated by that, which they are. The mesoderm of the sixth arch gives us all of the other muscles of the larynx, all the muscles of the larynx except the cricothyroid. So all the other muscles of the larynx come from the mesoderm of the sixth arch, and therefore all of those muscles should be innervated by that nerve, recurrent laryngeal, which is true. The neural crest of the fourth arch gives us the thyroid cartilage of the larynx. The neural crest of the sixth arch gives us the other cartilages of the larynx, primarily cricoid and arytenoid. Okay? So that takes care of the derivatives of all of the arches. Now, because we said that the first arch gives us the maxilla, and because associated with the maxilla is going to be the palate, we have to discuss that briefly. So from the first arch on the right and left sides, we have these what are called palatal shelves that grow medially from the arch. They're neural crest primarily, because bony structures from the arches are going to be neural crest in origin. And as these develop, they're going to grow medially, and that shelf will fuse with that shelf. Right? And then each of those shelves will fuse with this midline structure called the intermaxillary segment. And so this fuses with that, this fuses with that, and this fuses with that. With all those fusions, we now have a complete palate. Well, each place where it should fuse, we have the possibility that it doesn't fuse. So that means you can have a cleft of the palate here, or a cleft of the palate here, or a cleft of the palate here. So a midline cleft here, it's called a secondary cleft, is a failure of fusion between the right and left palatal shelves. A primary cleft, which is a laterally positioned or an anterolaterally positioned cleft here or here, is called a primary cleft, and that's a failure of fusion between a palatal shelf and the intermaxillary segment. So those are the places where cleft palate can occur. Upper lip is forming in a somewhat similar way. Again, you're going to have fusion lines here and here, and the possibility of failure to fuse leading to clefts of the lip. Clefts of the lip. Okay? So because we're dealing with neural crest and we're dealing with issues of fusion, you can certainly see there's lots of opportunity for abnormalities in palate formation leading to cleft palate. And of course, in the maxilla, we'll have teeth, and that will also be neural crest in origin. Similarly, in the mandible, there'll be teeth. That's also neural crest in origin. So this brings us back to where we started, way back at the beginning, when we looked at the germ layers and we looked at that chart of all the different adult derivatives of germ layers. We said, let's not try to memorize it at that point. Now that we're finished, we have covered just about everything in that chart at one point or another in our discussion. But I want us to, just for a moment, focus on just the neural crest portion of that chart. That's what I've reproduced here. This is the neural crest portion. And we've pretty well covered most of this. We pointed out that the adrenal medulla comes from neural crest. We talked about the ganglia, both sensory ganglia, like dorsal root ganglia, as well as autonomic ganglia, postganglionic autonomic cells come from neural crest. We didn't mention pigment cells, but they come from it. Schwann cells you'll talk about with neuroscience, but they come from neural crest. Some of the meninges come from neural crest. The pharyngeal arches we just finished talking about. The cartilages coming and bones from them come from neural crest, along with the teeth from the odontoblasts. We mentioned the parafollicular cells, also the parathyroid cells. And when we talked about heart development, we talked about the aorticopulmonary septum and the endocardial cushion, the neural crest. So, bringing us back full circle, if you recall when we talked about development of neural crest, we said that neural crest migration defects predict other neural crest migration defects. And so you won't be surprised to know that there are lots of syndromes, particularly genetic syndromes, in which there are multiple neural crest abnormalities. And so let's just think of one as an example to illustrate the point that I'm making. Let's think about trisomy 21, Down syndrome, and put aside for the moment the issue of the cognitive deficits in Down syndrome. And let's just think about some of the physical manifestations that are seen in kids with Down syndrome. We know that in many cases they have ears that are pinnas of their ears that are misshapen or slightly out of position. Remember, the pinna is from neural crest of the first and second arch. We know that these kids have a fairly high frequency of cleft palate, much higher than the average population. We just said that that's neural crest. They have a high incidence of abnormally shaped or missing teeth from the odontoblast. That's neural crest. They have a much higher than average incidence of heart defects that are either endocardial cushion defects or aorticopulmonary septal defects, or both. That's neural crest. They may have Hirschsprung's disease. That's neural crest. So the point being that neural crest defects predict other neural crest defects, and that's something that you need to be very cognizant of. So that if you were to be asked a question and you were told about a child who has one particular neural crest defect, and you're asked what other defect is this child most likely to have, you're looking for defects associated with these derivatives of neural crest. Okay. Well, we've now covered everything that we intended to. We wanted in this section to discuss the cranial fossae and the dural sinuses and how that all relates to hematomas and intracranial hemorrhages. We talked about the embryologic development of the pharyngeal arches and pouches and grooves and how that relates to the development of the face and palate.